Good afternoon, and welcome to today's PEMBA On Demand live stream. I'm Norm Chapin, your host for the live stream. Our live stream today is entitled Breaking Down Barriers, a Healthcare Lean Initiative. The University of Tennessee Haslam College of Business is the sponsor of the PEMBA On Demand live stream and podcast series. PEMBA On Demand has specifically been developed to provide education for physician leaders and to bring the latest and most relevant topics to you. Each live stream focuses on a different aspect of leadership, innovation, career development, or on the business of medicine. We really hope that you'll take full advantage of these practical, insightful, and relevant discussions designed to help physician leaders like yourselves to get new and to build upon existing leadership skills and perspectives. PEMBA On Demand will allow you to be an even bigger force for good in healthcare. As always, CME is available for this live stream. Visit the website tiny.utk.edu/PEMBA On Demand to obtain your CME certificate. So I'm pleased to introduce our guests on the live stream today, Karen Murrell, MD, and Chuck Noon, Ph.D. Welcome, Karen and Chuck.
Good morning.
Glad to be here. Good morning.
So Dr. Murrell is a practicing emergency physician, director of Care Without Delay at Kaiser in Kaiser Permanente, and she is a lean expert and consultant. Dr. Murrell is also a fellow of the American College of Emergency Physicians and faculty for the ACEP Directors Academy. She received her MBA from the University of Tennessee PEMBA program back in 2009. Karen also serves as a faculty member for the Institute for Healthcare Improvement and their course on hospital operations and emergency medicine. Welcome again, Karen.
Thank you so much, Norm. So great to be here.
It's great to have you. And Chuck, Dr. Noon, received his Ph.D. in Industrial and Operations Engineering, I believe from the University of Michigan. Is that correct, Chuck?
Yes, the national champions in football. Yes.
It always pains me to hear that, but I had to give you the opportunity to say it. And Chuck is professor, graduate in executive education at the University of Tennessee Haslam College of Business, and acts as a faculty for many of the university's executive MBA programs, including the Physician Executive MBA program. Chuck is also a lean expert and consultant with X32 Healthcare, and he also serves as faculty for the Institute of Healthcare Improvement, Perfecting Emergency Department Operations course. So welcome again, Chuck. We're really glad to have you on the show.
Glad to be here, Norm. Thank you.
So I thought we'd start out with some questions, and I'll direct my first question to you, Karen. You graduated from PEMBA back in 2009. Can you tell us a little bit about your motivation for enrolling in an MBA program at that time in your career?
Yes, I feel so lucky to be here talking to the other students and being able to connect with prior alumni. But I've been in emergency medicine my whole life. I just happened to get a job as a clerk in the emergency department at the University of Chicago, as I needed a part-time job when I was a student there. Then I went on and became a tech in emergency medicine. Then I was a helicopter dispatcher. Then I was a nurse for 7 years. Then I was a physician in the ER. And then I was moving up in leadership in the emergency medicine space. But I never thought you could do anything about weights. I thought weights were just part of what we dealt with in emergency medicine, just something we had to do. And I just read this little blurb from the University of Tennessee newsletter from my colleague. I did residency with someone you may all know, Jody Crane, who also teaches in the program. And he was talking about this thing called Lean for Healthcare. And at the time, now I think most people have heard of it and have done things with it. But at the time, no one had really done that much with it. And I went and took a 5-day lean operations course at the University of Tennessee, where I got to meet Chuck, who's become a really good friend. And it transformed my world. And I realized we don't have to do things in the way we've done them. And then I wanted to know more information. I wanted to know more about business. I wanted to know more about how we can really drive operational improvements and really improve care for our patients. And so that was my main motivation to go on to the MBA program.
Right. So it sounds like the reasons you chose to attend specifically the PEMBA program was your exposure to Jody and to the lean courses that were being offered by the university. And I know UT obviously has a very strong focus on lean. Were there other reasons that attracted you specifically to the PEMBA program?
Well, I love that it's a physician-only MBA. I love being able to have colleagues from around the country and around the world and get that exposure. And I think physicians, we've done a lot of training in the past and we have a lot of background coming in. So it's so nice to have a program that really allows us to build on the information that we already know in our prior education. So that was one of the main motivations. The other motivation, honestly, was that it was a one-year program, which I think is amazing for most of us who are very busy people.
Yes, that was a main attraction for me as well. I had tried for several years to fit executive education into my career, and the 12-month and holding myself accountable to get the work done in 12 months was a real motivator for me as well. So you mentioned you had already started to accept leadership roles in your emergency medicine career at that point. Can you tell us a little bit about where you were at the point you decided to supplement your education with the MBA program? What was your role at that time?
So when I took the course, the short course, I was an assistant director in the emergency department. And then when I came onto the PEMBA program, I was the director of our emergency department. And to be frank, we were in a kind of a crisis state. Our volumes were going through the roof. Our wait times were very long. There was a lot of information in our newspapers in Sacramento County about a little girl that had a very bad outcome from long waits. And so in my career, I had a lot of pressure. They wanted me to become to be the first trauma center in the Kaiser Permanente system. And we also had a huge psychiatric crisis in my community where we were boarding 20 or more psychiatric patients every day. And so I needed help, to be frank. I needed some help with some lean help. And also I needed that business kind of education to think about things in a little bit different way. I couldn't just focus on the medical diagnosis that we're really pretty good at as physicians. I had to think about things from a leadership perspective. And so that's what I.
Okay. So I think you've kind of answered this question, but a lot of physicians who are considering pursuing advanced degrees do consider other master's levels programs like a master's in public health or MHSA. Did you look at pursuing any of those types of degrees, or were you pretty convinced early on that the MBA would be the right road for you?
When I got into the program, I don't think I knew all of the advantages of the MBA program. I was kind of going because of my connections, but I really found by the end of the year, I really am so glad I went on to do my MBA because it's not only taking accounting classes, it's not only doing marketplace, it's not only doing those things. You really become a different person by the end of that year-long program. You really think about things in a new way. And so it was the multidisciplinary approach of the MBA program that really made it valuable for my career, I think.
Great. So what was the biggest, you said you really didn't know that much about it. I always like to ask physicians who go through an MBA, what was the biggest surprise that came out of the MBA program for you? What did you get from it that you least expected?
Well, for me, it's the relationships I developed and really hearing from people around the world and really discovering that entrepreneurship side of it too that I hadn't really been exposed to in the past. I'd been working for Kaiser Permanente, which I'm a strong proponent of, but we're really kind of an internalized organization. So seeing all of the different venues and all the different opportunities and all of those things was really the most important thing for me. And actually getting to interact with your small cohort through the whole program meant you actually make some lasting friends and things too. And you can always have someone to bounce ideas and things off of.
Yeah. So was there a trying to think of how I can ask this question because I want to follow up a little bit, but I think many people who go to an MBA feel that there's so many positive impacts on their career. It's a little hard to single one out, but can you identify a positive impact this has had on your career, professional development, or even personal life, or opportunities that this provided that you might not have had if you hadn't gone through the program?
Yeah. Yeah. Well, I guess it for within my Kaiser Permanente career, it meant a big difference. It made a big difference for me. So I went from being the director, and then I became the chair of the Chiefs of Emergency Medicine, for which for us meant I helped to direct our emergency medicine program across the whole continuum of Northern California, and we're the largest Kaiser Permanente organization there. And I could actually spread some of these principles to the other physicians there, and it actually helped me direct how I ran the meeting. For instance, I made people leave their phones at the door. We made them turn off their computer. We actually brainstormed. I used a lot of the techniques that we learned in our leadership classes to actually run those meetings. So internally, it helped me get promoted. But also, I feel so lucky to get my relationships with Chuck and Jody, because I think one of the funniest things, I still remember arriving in a snowstorm in the middle of Newfoundland at 1 in the morning, and being really afraid I was going to die out going off the road. But being able to work with people from other countries, and because what I learned is that it's the same problems everywhere. So I've been lucky enough to do some lean work and other principles in emergency medicine for sure, but I've also been able to do things in clinics. I've been able to work in hospital operations. That's what I'm working on now, hospital operations. I've been able to write a book on psychiatry. And all of those things were because of the relationships that I made, particularly with Chuck and Jody, who allowed me to pull along with them and do consultative kind of things. Also, it allowed me to get those relationships with the Institute for Healthcare Improvement. So now I do a lot of work with them. I was able to make relationships with people from ACEP, and now I teach at the ACEP Directors Academy. So it really allows us to spread that kind of lean work, and really allows me to teach that we don't have to do things in the standard way that we've always done it. We can make a real difference in our careers.
How do you balance? What are your current balance between clinical emergency medicine right now, administrative emergency medicine or administrative work, and the lean or performance improvement consulting work? How is that? What does your life look like in that respect?
I always say I'm going to wind down now. I'm getting a little bit older. I wish I could retire, but I haven't done that yet. But I'm doing about 50% clinical and 50% lean work on my current job. And then most of my days off, luckily, emergency medicine is pretty flexible. We don't have a 9 to 5 job, so I could kind of squish things together. And then I'm actually doing a lot of my consulting work on the side as well. So usually working more than full time, but maybe in a few years I'll be winding down a little bit. I don't
Yeah, it
know.
sounds like that adds up to about 150, 180% of full time if I'm doing the math in my head correctly.
Yeah, something like that. Yeah, yeah. But it's
Okay.
all fun too. I mean, that's the thing, that's it's kind of joyous work too when you make a big difference like that. It really, it's very rewarding, and it's always, for me, it's always about making things better for patients, but also easier and for people who are doing the work. So particularly now post COVID, I know we're going to talk a little more about that later, but we have this kind of low morale going around medicine in general, I think. So being able to give people back that joy and work is really makes me happy.
Right. Well, Chuck, I have a few questions for you as well, if you don't mind. Um,
Sure.
and Karen obviously has a lot of passion for organizational improvement, and you can just tell by listening to you, Karen, that you bring a lot of passion to that. I'm sure you bring a lot of passion to everything that you do. But Chuck, you came into this from a little bit of a different background, and can you talk about what your passion was and where it comes from for organizational improvement?
Absolutely. So, um, uh, factoid about me: I'm in my 37th year on the faculty at University of Tennessee in the College of Business. But if I go back and kind of look at my progression career-wise, I joined the faculty again straight out of an industrial engineering Ph.D. program in 1987, and did the regular, assistant, associate, full professor kind of theoretical focused research uh, until about 1998, and that's when the College of Business launched the Physician Executive MBA program. So I was part of the team that developed the program, and I've taught in it ever since. The great thing about teaching in that program is that you have this number one. I mean, you have mature, hardworking, very smart students. So that's always a joy to teach. The second thing is that you get this wonderful window into practice, into the real world. So my career then began to shift towards really trying to solve practical problems, and actually see the results of that application. And so that's what really kind of excites me personally is, I would argue it's like cutting your grass because you get immediate results and, a lot of enjoyment from that. So since '98, I learn every year when I teach the physician MBA students. I work on selected projects, throughout. And again, they're even when the projects complete or our involvement in the projects complete, we usually stay very close to the clients to really understand sustainability of the improvements, how they're performing, and in other words, truly engaged, truly invested in the outcomes that we are involved in.
So it sounds like you didn't embark on your career to specifically become as heavily involved in improvement projects within healthcare organizations. That grew out of, is it fair to say that grew out of the university's decision to develop the physician executive MBA program, and then as you got more involved in that?
That firmed it up, but when I was actually a master's student in industrial engineering at University of Louisville, I needed some living expenses, and so I took a job working for a healthcare consulting firm. So this is back in the early '80s, and I did some what were at that time there wasn't the concept of lean healthcare wasn't being discussed, but we were doing process analysis and so forth. So my first introduction to healthcare was in the early '80s as a master's student, but it wasn't until 1998 when the college made the decision to launch the healthcare MBA, the physician EMBA, and later on the healthcare leaders EMBA, did I really get involved in earnest. And to do that, of course, requires a large ramp up in terms of understanding that industry. I mean, among industrial engineering, it's very common to study manufacturing processes and making them more efficient and higher quality. But service operations like healthcare sometimes are not given the, I guess, treatment they should be.
Yeah. So I guess I didn't have that historical background. I didn't realize that you had started doing some work in lean healthcare before it was called lean healthcare back in the '80s.
Yeah. That's exactly it. Yeah. And when you're involved in, say, the launch of a physician executive MBA program, there's really, two things you can do. One is you just kind of consider it to be another teaching thing that you do, and you go in and you do your teaching. But what Karen alluded to and what really happened in my case was, began to establish very strong relationships with students after graduation, and they would see the value of involving myself in some of the projects that they had going on at their particular organizations. And we also saw the value of bringing them and their expertise back in terms of teaching within our physician EMBA program and other programs. And so it's kind of a two-way thing. And there are things I can teach about clinical operations improvement that people will, say, okay, that sounds really good. But when they hear from Karen or from Jody, from a physician leader who's got the clinical cred fully covered, it's much more profound in terms of getting that point across. So we've had a great time teaching these improvement methods in all kinds of healthcare systems, payer systems, international. Karen's been taught a lot in the Middle East. We've taught together in just a variety of settings. So it's been, and as she said earlier, the notion of doing things more efficiently, better for the patient, better for the staff, better quality. I mean, that's a robust concept. It doesn't matter who's paying who. That's certainly a robust concept.
And Norm, I would just say that the combination of having that clinical work plus the data analytics is so important. Chuck gives that lecture on queuing, and I was thought, oh my God, this is so interesting. I'm going to really become an expert on queuing. And then I got the math books, and I'm like, this is way over my head. But I think having the combination of the two of us together, or a combination of any clinical expert with someone who's an expert on the data, really makes the performance improvement projects shine.
So are you, with the consulting work that both of you are doing with Jody, I know we talked about X32 Healthcare in your introduction. Is that the vehicle that you use to do most of your consulting work?
Well, for me, X32 was a company that Jody and I created back in about 2008. And that was the vehicle we used to do lean education, analytic modeling, and also sort of on the ground consulting. So we did that over the next 10 years. And then in 2018, X32 Healthcare was acquired by Team Health. And Jody then became the chief medical officer of Team Health. He's still in that role to this day. And I continue to support analytics for Team Health in that capacity. So in more recent years, if there's an external project, and for example, the one we'll talk about here in a little bit, we just stood that up using sort of my own sole proprietorship, which is called Lean Analytics, and then just partner with Karen or Jody or any other individuals that can bring into a project as needed. So,
on average, how many consulting engagements are you involved in annually?
I'll let Karen answer that, and then I can tell you my own.
Okay.
Yeah, well, I do a lot of work with Chuck, obviously, and with Jody and with their company, but I've also done quite a lot of work with the Institute for Healthcare Improvement as well, and their arm, because they asked me to do a lot of consulting. I've been to Qatar 3 times last year trying to help them improve their flow in their emergency department and in their hospitals, where they had a very different system in place and a very different infrastructure in place. And then within my own internal organization, actually, I have a Kaizen event that's starting tomorrow if the ice storm doesn't derail it, which we're waiting for. And then, so usually I would say for me, in this new role, I'll probably do between a combination about 20 of them in a year, I think.
Okay.
Yeah. With respect to my own involvement, I tend to favor just a handful, but usually sort of larger engagements that might be like multi-point assessments, analytic modeling, teaching, and so forth. So, maybe average, 4 to 6 per year or something like that. And alongside Karen, I teach for IHI and made, I think 6 trips to Canada last year on just simply one multi-pronged engagement. So,
okay. So I'm really excited to hear and learn about the Lean Initiative story that you're about to share. But it sounds like you have slightly different. You talked about a big engagement, Chuck. What is that? A multi-visit type of engagement where you would go back several times? And Karen, were your trips to Qatar, were they for different engagements, or were they all part of the same engagement with just multiple site visits?
Do you want to go first, Chuck?
Oh, no, go ahead, Karen.
Oh, well, for Qatar, it was an initiative that was a year-long initiative where we went back multiple times and watched the project evolve over time and change things. So it was one large project. Within my current role, though, there's always with lean healthcare, you find that there's always room for improvement, right? You never, it's continuous improvement. That's the whole nature of the beast. So when I'm doing a local engagement, I really like doing these small projects where you can really get into the meat of it and fix a small problem that's really bothering you. Well, for instance, tomorrow we're working on low and medium acuity flow in the emergency department at one hospital. Then I'm going to another hospital next week, and we're doing the same thing. We're kind of mirroring the engagement, and then I'm hoping to bring Chuck on later in the year to really work on our radiology flow through the whole hospital. So there's any number of projects you can do. When I was working in Northern California, we did everything in the hospital. I was kind of joking that we were this Kaizen hospital, but any problem we had, we found that this was a method that really worked for us, that we would bring the multidisciplinary team together. We'd spend 3 to 5 days and we'd actually fix these small problems. So that way we were able to really improve our operational metrics. And by the end of it, we were actually performing in the 99th percentile of the country for large sized emergency departments, but it was step by step by step. And we do things in the urology clinic, we did a project in the pharmacy where we were looking at things. We did things all over the organization, transportation, everything.
Right.
So to answer your question about the multi-prong. So for example, last year through Team Health, we had a large engagement with 4 separate hospitals in the Ontario province. And, there were numerous visits, one involving, or several involving what are called assessments, where a small team goes up and we intensely interview and do data analysis. And we try to look for the opportunity for improvement. We try to identify what are the barriers and then what's the delta. What could you really attain by focusing on a particular aspect of in our cases, usually it's patient flow. We would then come back to sort of prep the improvement event by some education, and then we would conduct an improvement event with a subset of the folks from the course. And again, as Karen mentioned, our sort of style of choice is usually, after some education, perhaps a 3-day improvement event where you're planning and getting things set up on the first 2 days. And then on the third day, you're actually testing a new process, which either, takes a life of its own right there, or you learn a lot about it and you come back and repeatedly pilot. And that's what we did, for example, with the project we'll talk about in a bit at Boston. So.
Yeah, I'm excited to hear about this project. I know we've talked a little bit about it in preparation for the live stream, but I think this would be a good time to transition into your presentation and kind of have you share with the audience a little bit about the project, how it developed, and the types of things that you were working on, if that's okay with the two of you.
Yep, sounds great.
Okay.
So I'll talk a little bit about the genesis of this project, first of all. So Karen and Jody and I teach in the Institute for Healthcare Improvement Emergency Department Improvement Initiative. And we had some students that attended that from Mass General Hospital. And so then they invited the 3 of us to come back and teach a one-day immersion into the notion of lean improvement. So Karen, Jody, and I went to Mass General Hospital to their ER and taught that group. Well, one of the individuals from Mass General, who was the champion of that one-day course, took a position, Brian Yoon is his name, and he took a position over at Boston Medical Center. And so then that was that relationship that later, caused him to reach out to say, hey, can you all maybe come and take a look at our ER? And this is back in 2022, and it was in the throes of lean, and we've got all kinds of challenges in terms of staffing and so forth. So The reason for the project was, first of all, they are a level 1 safety net hospital in downtown Boston. About it's a high volume, about 350 patient arrivals a day, about 20% admit rate, and so they were having a lot of challenges in terms of long length of stays, fairly high rate of patients leaving without being seen. And a lot of that was due to the fact that there was a perceived bed shortage in the emergency department. Now, that bed shortage in the emergency department, if you know anything about queuing, is that it stemmed from the fact that they were having trouble getting patients upstairs. In other words, admitted patients were being held in the ER, basically tying up the treatment beds. Now, when we, their current state at the time was that down the hall, actually a pretty good little walk, was a fast track. And so they would see they would direct the low acuity patients over to this separate 10-bed fast track area. So that was the setup. But everybody else who were mid acuity or more serious acuity would head over to the main side, and they would do their best to try to see all those patients in a timely fashion. But at the time of them reaching out, their metrics, they were not meeting their goals, and were looking for what would be some high leverage points of improvement. So if you go to the next slide, what we did was we started with, first of all, an assessment. And so Jody and Karen and I went up and we interviewed and we did analysis, and we realized that there were some opportunities in terms of patient flow within the emergency department. And also we were questioning whether the wisdom of having the separate 10-bed fast track geographically away from the main side was the best way to do that. So we then came back and we conducted a 2-day sort of lean improvement course for about, 30 folks from the ER. But it was a good cross section of providers, of nursing, of registration. We had lab, radiology, some folks from the inpatient side. So anyone that could possibly affect the flow had a representation in this course. So if you continue on then, so the next step in this sort of multi-prong, so we've done the assessment, we've done some education, but a subset of the folks that attended the course then attended a 3-day improvement event that was facilitated by Karen and I. And again, it was about 15 folks that were involved in that improvement event. And you can see the list here. It was a good representation of all the people involved in patient flow within the ER for sure. But it's not Karen and I standing up at the front of the room telling them, okay, we've got the solution and this is what we think it is. It's really about sort of objectively presenting the data, hearing from them what the challenges are, and hearing from them in terms of what their ideas for improvement are. So it's true facilitation as opposed to us dictating a solution. So, for example, here we've got the layout where we're starting to consider options in terms of handling the lower acuity or mid acuity patients, and we're noting one such thing is the change in the possible location of treating those patients. If you go to the next slide, you'll see that we also, of course, part of any improvement event like that is mapping. And we start out by, saying, hey, how are patients currently treated? How are these low and vertical mid acuity patients treated? And let's capture all the steps involved in that. And so that's the current state. And this is kind of classic sort of lean Kaizen approach. And then we challenge the group to say, can you come up with a future state? In other words, what could the process look like? What would be ideal from the patient's perspective? And so, after getting all the various handoffs and steps captured for what the current state was using, we then got to a future state that really involved only about 5 steps. Just come in, head to the right direction, and get the team-based care and so forth. So if you roll to the next slide, we'll see that, so what were the elements that we were going after? And so what we had sort of analyzed and we knew was a good opportunity was that if we could reduce the load on the treatment beds, then that would help, clear a lane for the patients that were currently, some of them, higher acuity patients that were sitting in the waiting room. So the question is, can we reduce the footprint of bed consumption by these low and mid acuity patients? And so some of the elements that we arrived at and then decided to test was this notion of, a patient walks in the door and the first point of contact is with a pivot nurse who, following some very strict criteria in terms of inclusion, either says you're eligible to go to this, streamlined low mid acuity area, or no, you are, you need to head to the main side as soon as possible. So it was a very sort of quick but rigorous sorting, if you will, saying, hey, you turn right and you turn left. The patients that turned right into the low or vertical mid acuity area, the whole notion was like keeping them vertical. So don't have them lay down and take up an examination room if you can any way avoid that. If they need an IV, there are some recliner chairs that you can sit in and do that. If you are waiting for test results to come back, there's a designated waiting area that you can wait in and not be tying up one of those beds. The other thing was efficiency in terms of telling the story. So a patient comes in, they get directed to this area, and then there is a doctor and nurse team that walks in together. They've got, computers there, and both the doctor and the nurse are asking them questions, doing their assessment. They're hearing it once. They're documenting as they go, and super efficient communication between those caregivers. And then another thing is that, there's patients going there. Some of them need, of course, lab work. Some of them need imaging and so forth. So we wanted to minimize the delays of turnaround time for whether it's lab or for imaging. And so it turned out it made sense with the volume that we were going to be able to direct to that area. It made sense to dedicate a transporter just to keep those imaging patients moving very quickly. So again, this was a rather large, new process to test. It involved a new area. It involved new processes. It involved even clinical decisions with respect to PO meds versus IV meds and so forth. And everyone had to know their role. And so it was a tough order to get this all together in the first 2 days of the improvement event in order to be able to test it on the third day. So Norm, if you go to the next one, I love this, layout that we have here. And that is, this is this rapid assessment zone is what the team came up with. And on the right side, patients would come in, they would hit that pivot nurse. And if they were eligible for this low vertical mid acuity area, they would go to the right, and they would go in, and when their name was called, they would go into an examination room. The doctor nurse would do the assessment. If they needed blood drawn, there was a little lab station right there. If they needed imaging, there was a transporter ready to take them to and from imaging. It was all in this very compact area. It was only about a total of 7 treatment rooms that were consumed by this design. So, there was, of course, 4 examination rooms with 4 potential teams of docs and nurses, but there was also a pelvic room. There was also a procedure room. There were, as I mentioned, there were recliners for patients that needed hydration and so forth. But this sometimes we think bigger is better, but for lean flow, the notion of compactness, which minimizes walking for patients and caregivers, but it also enhances communication between the groups. So that was, what we cobbled together. And then if you go to the next slide, this was just a kind of overview in terms of the group right before we started the pilot on day 3 of the improvement event. And they worked tremendously to get things ready. Everyone, well, I should say most everyone brought a great open mind, although we'll speak a little bit about pockets of resistance that are naturally going to occur in these kind of endeavors. But the team came together. It was like literally, getting ready to play a championship game. I mean, it was like, all hands in and let's get this going. So if you go to the next slide, we'll show you sort of what some of the first looks at performance were, and that was on the left side of each of these pairs of graphs are showing sort of what the baseline performance was, and so the right bars on each of these sides represent this new process, which is called the Rapid Assessment Zone, the RAS. So for the low acuity patients, they were able to reduce length of stay by about 43 minutes. For the medium acuity patients, for the vertical ESI3 patients, they were able to drop that actually almost 3 hours. So the pilots demonstrated what could be done in terms of streamlined patient flow through a relatively small footprint. So, and again, different than the fast track before, this took much less floor space. Plus, it started to involve the mid-acuity, the ESI3 patients, which are the largest swath of patients that come into an ER in the first place. And those are the ones that can potentially be the most dangerous because, you want to get those patients assessed as soon as possible because you're not sure if they're really sick or they're not. Now, if you, so this is great. And from a temporal standpoint, it was delivering. And so if you go to the next slide, though, you'll look at what was happening in terms of top box scores for patient satisfaction. So during the pilot, even we had constructed, little surveys for patients to answer, but also, and I don't need to go into the details of this, but basically the new process relative to either the pre-existing fast track or the main side ED was a very significant jump in terms of patient satisfaction. Because again, at the end of the day, patients want to get in and be seen and be treated and move to the next area of care or to be discharged home. I mean, it's kind of a simple formula in a way. So if you go to the next slide really quick, and this was now a project that after the success of the implementation of the RAS, then we got a call back from Boston Medical and said, hey, we've now done a lot of things in terms of improving our emergency department performance, but there are some processes that now go outside of the walls of the ER. And one of them was, say, imaging and lab turnaround time. And so we basically worked with them and said, hey, you know what? We think there's a big opportunity in terms of CT turnaround time. And so again, and I don't want to dwell on the analysis, but this chart here is kind of very telling. So the blue bars represent CTs being ordered by hour in the ER, and the orange bars represent the CTs being started in imaging. So every time the blue bar is bigger than the orange bar, that means you're naturally building up a queue of patients who are waiting to be get their imaging studies done. So and the little skinny line at the top basically shows the order to begin time. It naturally is going to increase over the hours as this imbalance is occurring. So then the natural question is, you can't say, well, order less CTs from the ED. But what you can do is say, what can we do to improve the throughput rate for radiology, in particular for the CT unit? And so if you go to the next one, again, we always, by the way, we feel data is the great objectifier, data analysis, because it is what it is, and it can really help target opportunities for improvement, and also gives you a basis for comparison later on. So, we looked at basically the key intervals of this process between ordering an imaging study and having the final results back. And if you look at, I'll just cut to the chase here on this very top line is the order to final results, and if you look at the lowest part of that line versus the highest part of that line, one can make the case that says, well, why can't you just perform at the lowest part of that line throughout the entire day? And you can actually ask the question that says, for each of the component intervals, can you, if you just took the minimum of each of the lines below that, then that's what you're clearly capable of doing. So if you go to the next slide, we went back, did some more education, and then we did an improvement event. A colleague, Keith Leitner, and I did an improvement event focused on CT turnaround time. And again, we reduced the changeover time to make better use of the CT scanners and the technologists. We worked with transport. We took care of sort of a nagging label printer issue. We made sure there were ample lab tubes, canisters for creatinine analysis turnaround, made some little layout changes, got the right amount of staff in place, and deployed this new process, across all the nursing staff in the ED. And so if you look at, I'll show you one final slide, and that is the results of the pilot. And again, you set this pilot up, and then you run it on the third day, and then you compare how prior days' performance looked in terms of the turnaround time by individuals needing CT scans, and then you compare that to what was delivered in a streamlined fashion on the third day. And and that is exciting. That is truly exciting, because now they did both for the RAS as well as for the CT process. They did a number of pilots before actually turning it on and going live with it. So the CT process just got in place permanently in early December, just about a month ago, and they're still continuing to improve and tweak it and have it get close to delivering the pilot kinds of results. So again, this is just kind of an example. It started with assessment. We do some analysis to see what the delta is, the possible opportunity is. We feel it always works better when there's an installment of some education, especially related to lean healthcare. And then the facilitated improvement event. And again, these were not, they're not sort of easy. And there's an old saying that says, if it was easy, everyone would be doing it. And clearly that's not the case. A lot of organizations, the default setting is to not change. And so it's not until you as a physician leader are able to paint that future state and you're credible in terms of being able to attain it, then you'll get their attention, and they will follow you at least to try that out. And that's what I think the physician leaders bring to this mix tremendously, because again, if I was there by myself, and there's a lot of things clinically that people could challenge me on, and I wouldn't be able to respond to. But when I'm there with a Karen or Jody and so forth, they can respond to that, and especially it gets the attention of the other providers, on the teams. So with that, be happy to. Karen, you want to add any color to this?
Yeah, I definitely do. And the one thing I want to say is that this project had a couple key things that are necessary for it to really work. It had a really, really engaged leadership team on the ground, that they had this real vision for where they wanted their place to go. And I think that us as PEMBA leaders, we can set the vision for the people on the ground. And the other thing that these improvement events really do, there's two things. There's the process part that we're going to work on and we're going to help them get there, but you're also creating this culture of flow and getting people engaged and really wanting to do this work. And so once you've done the one project, it's a lot easier to do the second, third, fourth, fifth that you need to do. Yeah. And this idea of continuous improvement. The other thing I'll say is that as someone, as humans, I think that both Chuck and I would agree that we really do not like change at all. And it's really, you're always going to meet that resistance. So I've come have this kind of as a mantra of expect 90 days of pain, that, as you're rolling things out, there's going to be this resistance and this pushback. But if you hold the course and let it get over the hump, it becomes part of the culture and it becomes part of the organization. So it was a really great project. And I think because they had those amazing physician leaders and they really set the standard and the vision for where they wanted to go, that these were a success.
Thank you both for that presentation. That really is a good example of impact that you can have on an organization through some of these methodologies. I was interested, you mentioned, Chuck, and I guess, Karen, this is a question for you. This started sort of at the tail end or near the end of the biggest surge in the COVID pandemic in 2022. And in my experience, that was a very tough 2 years for emergency departments and healthcare organizations in general. You mentioned the staffing challenges that had been faced, and a lot of times my ER docs felt like they were practicing out of the waiting room that whole time because they just had so many flow problems in the emergency department. So you alluded to some you alluded to some barriers that you ran into when you were trying to implement this project. But in your opinion, were these barriers sort of unique and related to coming in on the tail end of the COVID pandemic, or were they things that you had seen in previous years?
I think there's some general problems that we see in almost every emergency department now that we've been to thousands of them. Probably we can walk in and see these general problems. The COVID pandemic did bring a whole new level. I think I've never seen morale as low as I've seen after the COVID pandemic, particularly in emergency medicine. So what I like about these events now is we can start to bring back that engagement and that physician involvement. And the other thing that I think is us as leaders is that we really do have to set that vision that, for instance, my vision for my place was our patients don't wait. So we can't accept conditions no matter what they are. We have to figure out new creative solutions because I don't think anyone would design healthcare the way we practice it now if you're a Google engineer or something like that. So I worked in one emergency department where every single bed was full of boarders. And I think that's what's killing emergency medicine right now isn't emergency medicine patients, it's the boarding that we're seeing. And so we knew that we had to do things in a different way. So we had to be very creative and design a system using minimal nurses because the nursing staffing is so low right now, where we'd have one nurse at the front, one nurse at the back, and we just load every single patient through this little like a turnaround merry-go-round system where they could go get their labs or x-rays. And the physician who was going to take care of them came in there in an assigned and methodological, in a very standard work kind of way that they knew that that was their patient. So it allowed us to know which patients were the sickest, and we always had our eye on the waiting room. So was it pretty? No, it was really ugly. It was waiting room medicine, but at least it allowed me to have some autonomy that I could practice the way I wanted to. I could still order my tests. I could still get the things done. I could still get treatments, and I could prioritize which patients needed to be brought in emergently. But we had to think in a very different way that we never thought before. And so I'm convinced that lean healthcare and this performance improvement is the way we're going to start to improve our physician and our staff morale and maybe get it back to where it was before the pandemic, hopefully.
Great. Thanks for those comments. And Chuck, one of the things that and you made a comment earlier about lean healthcare improvement projects are like mowing the grass because you can see the immediate and tangible effects. But I've seen a lot of organizations that, like mowing the grass, you look out at your grass a week later and all of those changes and the beautiful lawn that you had has kind of gone away. So can you share with us, are there any particular predictors of sustainability that you've identified when you go in to do these lean events that you include in your education for the leaders in the organization so that you don't come back in 6 months and find that the grass is all grown up again?
A great question, Norm. Indeed, and Karen mentioned this as well, is it really takes commitment by administration, management, leaders in the organization. If they're trying to hire a consulting group to come in and outsource improvement, and it's not in the DNA of the organization and certainly in leadership in the organization, it's doomed to fail. And so one of the things we loved working with Boston was not only were they taking it very seriously and early on, that was very apparent, but their persistence after the initial pilot test, and they would never finish a pilot without scheduling the next one. It wasn't like, let's try this and then, we'll maybe try to come back and do it again some other time. They were very firm, so they managed the project very well in that respect. And I want to just tack on to something that Karen said, and that is, what we saw with COVID and especially inpatient staff shortages causing holds and queued up back into the ER. There was a tendency also for sometimes like the ER people to say, like, there's nothing we can do because we've got all these holds. We're a 60 bed ER and we've got 30 holds. And so we're not going to do anything until the inpatient fixes their side of the house. And, my sort of question back to them was, okay, well, if you've got a 60 bed ER and 30 beds are chronically tied up with holds, are you running a world-class 30 bed ER? Like let's do the best. Let's accept that we've got a set of resources that have been taken away, and let's do what we can with what remains. And that was why this particular project of a small footprint, streamlined patient flow for actually about half of discharged patients go through this area each day. So I mean, it's this mighty set of rooms in terms of volume throughput, and then the CT turnaround time is, I mean, the math is all there. If in their case they were able to shorten CT turnaround time with contrast by 2 hours, and they were doing that for about 30 patients a day just in the ER. So you say, well, okay, 30 patients a day, you're shortening their in-bed length of stay by 2 hours. You just freed up 60 bed hours, and so during the peak period, that's like building out another 5 beds right there.
Right.
And so that's how the math works. So
great. The one thing you mentioned, both of you kind of mentioned this, as you said, the commitment of the leadership. So when you were doing the Kaizen events and the improvement events, it sounded like you had a lot of local frontline staff and leaders from within that area, whether you're talking about radiology or talking about the emergency department in this case. How do you engage the executive suite, or do you engage the executive suite in these activities in a way that you found to be more beneficial in terms of maintaining and achieving that level of sustainability?
Yeah, for me, having that leadership engagement is so crucial. So I think when we first go into a place, of course, we meet with the leadership team very first thing. And then we usually ask the leadership team to come at the beginning of one of these events and let the frontline staff know that, hey, this is so important to our organization. And one of the most powerful things to me is having each member of the frontline staff give part of the report out at the end of the third day. So each person, housekeeping could be giving the same talk as a physician, each person having a slide with their role in the department, talking to the hospital leadership team. Sometimes it's almost made me want to start crying because they've never had that voice before. And then having that leaders tell those leaders say how much they really appreciate that work. As we went forward with some of our events, our C-suite leader would often come down and round in the emergency department, and it let those frontline staff know, hey, he's still engaged, he's still interested. And then all of them would talk about it and were willing to try the next thing. So I think it's critical.
Great. Well, I'm going to switch over now. I forgot to mention this at the beginning of the live stream, but we do have time for some questions for Chuck and Karen. If you have a question for them, please enter them into the comment section, and we will address those. So we had one comment so far from Mike Shearhorn, who is just passing on his accolades to both of you, that he's enjoyed listening to the lectures and that kind of thing. So I thought that was great. But I really appreciate the time that you two have taken. I know that your schedules have been very busy, and Karen, yours especially has involved a lot of travel in the past week. But I appreciate you both making time to come on the live stream. For the audience, we will be releasing this as a podcast next Thursday, both as an audio and a visual podcast. So that will be available to you either on Apple Podcast or on Spotify, Google Podcast, and you'll also be able to see that visually at the YouTube channel, which we have Pemba On Demand. So those links have been in the messages and the communications that have been coming out from Kate Ashley and from Tom as well. So at this point, if there's no more questions, I will close by just reminding you that you can have CME for this event by going to the website, and I will post that up here in just a minute. But thank you all for joining, and I look forward to our next live stream next month, where we will be having some more very, very interesting discussion with Pemba alumni.